But what I want to do is start with just a case that's in our virtual internship, and we want to walk through it because this is for you. This is for you to learn. Coding isn't something that you learn just by picking up a book and reading through it. We've got to make sure that we stop along the way as we're learning and we look up so that we understand. And I'm going to show you some examples of what I'm talking about. This is a gastroenterology case. And what we've got here is an endoscopy report. All right, so I'm going to read it. And I might not read it exactly verbatim, just in the lieu of time, but I'm going to get the point across, okay? So I've got the name of the procedure, esophagoscopy with biopsies. Now, let's say I'm in the office and I'm coding this operative report. What am I doing? I'm actually writing down, all right? I see my procedure. It says esophagoscopy with biopsy. So I wrote that down. All right. Then my indications, this patient's got a history of now I might not know how to pronounce all the words, but you should be able to read the screen. Eosinophilic esophagitis with dysphagia and periodic food impaction status post-treatment, and he's been on Prilosec for multiple months. Okay, the procedure's being done to access the response and the need for further dilation. All right, I've got that. I've got no significant history. There's no diagnoses in here that would contribute to any type of complication that he might be looking for the patient while they're under any type of anesthesia. He says the medications, the list was reviewed. We don't have that in this chart. But then he does the physical exam. So is there anything here that I can make notes on? I've got no murmurs on my heart. Lungs are clear, abdomen soft, non-tender. There's nothing to write down there, right? Because
so
it's pretty much
that means there's
normal.
no complications with the physical exam, right? There's nothing,
right.
No other things being seen.
Right. There's nothing, there's no other diagnosis. So far in my notes, I have history of the esophagitis with dysphagia. Okay, so that's what I've wrote down before as I went through. All right, next I've got an instrument, a GIF 180. All right, I need to know what that is because I have no clue. And I'm trying to figure out, I want to make sure I code this procedure with everything he's done. So I Google. When you see something, because if you're using an instrument, that's a very good question. And I want them to make sure they make note that you've got to find out. Google is your best friend. Don't go out and buy a medical dictionary. Google. And when you Google it, it simply tells you it's a gastroscope.
But here's my question. Here's my question.
Okay.
For a student who is taking the exam, limited to the Find a Code and the CareerWize exam, how would they know what that is? How could they have access to know what that is during the exam?
I'll respond to that. The scenarios that you code on the final exam have been very thoroughly vetted. There's no ambiguity. You can answer all of the testing questions with what you're provided access to, which is your Find a Code, and the LMS where the content is. We've been, Faye's pointing out, because when they get in the real world and you're coding, you need to know what this gastroscope is. You may not know what a GIF 180. Even Faye said she didn't know what it was, but she went to find that out. But on the test, so you don't know what GIF 180 is.
Right.
You've never seen
it
before? that what you're saying, Faye?
Yeah, as a coder.
Yeah,
Okay.
It's not,
I'm coding this
new to
chart.
you. Mm-hmm.
Okay. But as a new coder, I don't know what this is. I will after I code a few of these because they use these. It is a gastroscope. What is that? What does a gastroscope tell me? Tell me, one of you two tell me, what is a gastroscope? Break down that word for me. Can you tell me? All right, think about it. What's gastro is stomach. Scope is visual. So it's going to look at the stomach area.
I'm going to say it's some sort of device that he's using to evaluate the gastric
esophagitis
of the patient.
Yeah, our gastric system. Okay. Medications, the patient received the sedation per anesthesia. Well, I'm not going to code that because I'm not coding anesthesia. All right. I'm not the anesthesiologist here. I'm the surgeon. I'm working for the surgeon. So I want to pick up what the surgeon did. All right. So we've got an informed consent was obtained. And in an informed consent, it discusses that it's limited to risk of perforation, bleeding, and the need for surgery or transfusion. Okay, so that's what an informed consent is. That's basically what that is.
Do consents, obviously the patient has said, yeah, I understand there's risk with this procedure, but go ahead and do it on me. Does that affect coding ever, Faye?
No.
Okay.
Yeah, but they put it in there for legal purposes. It's part of this report is their legal documentation. So if this patient sues this physician, takes them to court, that physician has it documented right here along with a signed consent form. So you're seeing that he's very careful and that he knows that he has the consent from this patient to perform this procedure. So he's going to put it in his op note. In the left lateral decubitus position, after intravenous sedation, the flexible endoscope was inserted without difficulty. All right. So that flexible endoscope right here.
That's the GIF 180.
Yeah.
Oh,
okay. Now that we've got the scope in there, we're going to look around. Examination of the esophagus reveals subtle rings. And that's just, if you think about how the esophagus is, it is rings as it moves, as it goes down. Okay. So he's just describing what he's seeing, but there's no abnormality. They were less pronounced than on the previous exam. So what does that tell me? Last time there must have been something going on with them because they're not as vivid this time. They're subtle. They're there like they should be, which was obtained. So there were no inflammatory changes. We've got no sign of any changes there. The esophageal walls were quite soft and pliable. A small hernia was present. All right, let me write that down. Okay. Write down the hernia.
Okay, I have a question.
Okay.
I'm going to join these students because I'm not a coder. But okay, when he went in and looked at the esophagus and the rings were
subtle,
less pronounced than a prior examination, is that noteworthy? I mean, the fact that something changed?
No, because he should tell us through this report what those changes end up being. You know, what does he find? And we'll see that when we get to the impression. Okay, so what that sentence is really telling us is that the patient's improved, that his esophagitis has improved because it's less subtle now, but he still has it. It's still ongoing. He didn't say it's clear. He just says it's less pronounced.
Okay.
Okay. All right. So then, did you write down your hernia?
Yeah.
Okay.
It's the only thing noteworthy so far.
Yes. Then we have a retroflex view. All right, we've got the hernia. We've got the fact that the stomach was normal. But then we see that biopsies were obtained. So I'm going to go ahead and write that down. All right.
Why is that important to note when you didn't take note that a view of the stomach was obtained also? Is that important?
Well, no, because you think about it. He's got the scope down my throat. He's just telling you what I see, what he sees.
Okay.
So the stomach was normal. It's part of this procedure. It's what the gastroscope is looking at. Okay. But we need to know that biopsies, that's a separate procedure, because you've got viewing of the stomach and then you've got a biopsy. You won't always see that a biopsy is done in a gastroscope. So that's important. You've got to pick that up in your coding. All right, so let's see what the impression is. Clinical and visual improvement of the esophagitis, which is validated by the fact that up here he says, examination of the esophagus revealed subtle rings which were less pronounced than the previous exam. Okay, so basically it's improved. And that was the impression at the end of his viewing. And then he found a hiatal hernia, which he listed. Keep in mind that this physician listed hiatal hernia, but they don't always, because that's your job as a coder to be able to read that report and pick out your diagnosis. Now, the majority of the time they do, but I've seen many times they don't.
So
and that's why we wrote down our
questions. So if he didn't list item 2, the hernia, in his impression, even though he documented it above, would you still code for it?
Absolutely. You can code from the body of an op report.
So you're living on every word that's included by this physician when he documented what he did.
That's correct.
Okay.
Yeah. That's why it's important that when you went through your medical terminology, that you understood, you comprehended, and you retained those prefixes, those suffixes, those root words. Do we think you can remember all of them? No. But if you're looking up words as you're still in the course and you're studying, practice will help you to retain. But if you don't look up these words and try to understand what they mean, you're not going to be successful. You have to understand what this report is saying, because I'm coding this for a physician. He will be reimbursed by how I code. And if I don't get it correct and he gets the wrong amount, then I'm in trouble. So the importance of taking the course from A to Z and not just reading, but actually thinking about it, doing those exercises until you get it, not until just you get it for a score. That's not what it's about for you. It's about understanding. Okay? All right. So, all right. What have we got to code here? The recommendations, they're just going to continue the Prilosec, and he's going to follow up if symptoms recur. What have I wrote down on my notes that I need to code? Tell me what I'm supposed to code, Blessing.
All right, Blessing.
All right. You code first the eosinophil esophagitis as the first listed diagnostic code. then followed by the hiatal hernia as the second diagnostic code or the secondary diagnostic. Those are the two things to code because they didn't show of any food impaction during the view.
That's right. Okay, what's my procedure?
Then the procedure is going to be esophagoscopy with biopsy. I can't get the code right now.
Pardon me?
I don't know the code yet. I don't know the code of it, but if I look through it, I can get it.
Very good. Very good. All right, let's code it.
Let me ask a question. So Blessing was saying that he wants to code the diagnosis first. Is that the right approach? Do you always want to identify what are the diagnoses here before you do procedural coding?
No, you need to identify everything.
I understand, but do you do one before the other?
Oh, yeah. Yeah. And
okay,
because coding that procedure is not going to affect how I code my diagnoses. All right, let's do it together. You ready?
Yes.
All right, so let's do the diagnoses. I've always, in my past, kind of like Dave was alluding to, I've always done the diagnoses first. Let's look up. All right, let me look at my notes right here. And I've got that, see if I spelled it correctly as I wrote down my notes. Oh, it's going to cheat because I already looked it up. And I'm going to type it in. All right, then I'm going to search. I spelled it wrong. All right. Well, it come up first right here, but I can't stop there. I'm not going to stop just because this tells me exactly what I typed in. I'm not going to learn anything if I stop there. So I'm going to open it up. And I'm going to look. And I see right here, this eosinophilic esophagitis. That's probably my code. But I've got to learn because I'm a new coder. I'm putting myself in your place. And by learning, when I open it up, I see that I have a lot of instructional notes. All right, it tells me to use additional code to identify alcohol abuse and dependence. I didn't have any of that.
So I don't. Yeah, didn't see any notes about that.
Nope. So I could disregard that. And excludes one note tells me what? If one of these diagnoses are listed in my documentation, I cannot code it with K20.0. See, when you were learning the coding guidelines, all this was mentioned about what excludes one and excludes two notes. Okay. You don't find those notes unless you open your code up. Okay. So if I had any of these diagnoses, erosion of esophagus, esophagitis with gastroesophageal reflux disease, reflux esophagitis, ulcerative esophagitis, if I had any of those, I could not code them. I would have to go back into my chart and rewrite my diagnoses and figure out what I need to code. So we don't have that. We don't have to worry about that, but you might and you will. Excludes two, what does that tell me? I see that smile, blessing. All right. So if I see an excludes to note, then I can code it there. If this patient had eosinophilic gastritis as an additional diagnosis, I can code it. All right. Uh-oh, I see hiatus hernia. Can I code it?
Yes.
Thank you.
Correct.
Very good. Yes, because I've got, it's under an excludes to note. All right.
So I have a question. So the excludes one, Faye, they're in red because you cannot include them.
You cannot code them with this code.
Okay.
So apparently I've got to go back to
So
my
red means like
chart.
no.
Yeah, stop. Can't put it here.
Okay.
All right. So we're not going to read all these excludes to notes, but we see them. And what I want you to see, because this is important, this common language description, this is your definition of the condition of the diagnosis. And it's important that you read that. We are not rushing through this course on a timeline. We are getting through this course to learn. And if we don't know what our diagnoses and procedures mean, we're not learning. So please take the time to read the definition. It doesn't take that long, and it pays off tremendously. Because let's say in the real world, you actually get a job with a gastroenterologist. You need to know his language because he's going to be writing and documenting words that pertain to our gastric system. So right now is your time to learn, not when you get on the job. We want to come onto that job and we want to know it all.
So
but we want to.
So it describes what this condition the patient has, that they've got some sort of an immune system thing going on, a virus or bacteria or something that's causing this. Huh.
That eosinophilic is a type of organism that grows. It's an infection. And it has grown, it's in the esophagus. But this gives us a little bit more information to help us better understand it. All right, so then see the pluses down here where you can open up the section codes. This is what you've got in your studies. This is what we went over through your course. We went over the guidelines, the documentation guidelines. Have you taken the time to actually scroll down and open up and read and learn? Make sure we do. All right. So let's write down that code because we have to enter that. K20.0. Any questions before we move on to hiatal hernia?
Yes, I have a question.
Okay.
All right. Going down the find my code, there are some columns that can't open for us. They ask us to subscribe. Like some of the information is down. We can't really access them.
Some of it is not subscribed through. Is that what you're saying?
Yes. Like
okay. And that's correct. That's correct. I don't know if this is or not. We made some changes yesterday. But I know what you're talking about. There is reference material that we were not getting, that we did not have subscription to. If you didn't have subscription to it, it wasn't that you had to have it. It wasn't needed. All right. Now we do now have Coding Clinic, and
Is blessing, are you saying you don't, Faye's view of find a code is exactly what the students have?
Yes.
Is it not? Yeah.
Do you have all this?
You should have all that you're seeing here, the students, it's all available to all of you.
Okay. What I think he's saying is like when you open this and it says subscribe, Blessing, you don't need that tool.
Yeah.
If it says subscribe, you don't need it. So,
Yeah.
So we only want you to have what you need. Our goal is to make sure you understand what to code, how to code it, and what it means.
Isn't it true when these guys are out working as coders and they've passed their exam and they're working, there are certain rules, right, for different payers or different wherever the service might have been rendered, policies about certain things, right?
Right. Good question. And let's talk about that.
I know they don't probably have to worry about that to kind of earn your certification and pass your certification exam. But when you're working in the real world, these are things that you have to deal with.
Okay, what happens is when you're hired and you're coding manager, you're going to have a supervisor, you're going to have a manager. And they're going to tell you that their system is built, their coding system, like we have our coding system, okay, and like Find a Code, and they may use Find a Code, they actually plug in the rules that are set by the LCDs, the local coverage determinations. So if you code something that is against Blue Cross in the state of Florida, it's going to red flag you.
When you're working, they'll be given to you by your supervisor. They'll make sure that you don't get too far afield and that you follow those local rules. Okay. As
long as you can assign the correct code, you're on the winning team. All right. So did we write down that code? Because we got to make sure we don't forget it. All right. So I'm going to go back here. And what's my next diagnosis? Hiatal hernia. All right. That's my CPT codes. I'm not into that. All right. I don't see the word hiatal. So I need to know what a hiatal hernia is, don't I? So I'm going to Google. If I think about Google, and can y'all still see my screen?
Mm-hmm.
Yes.
All right. Hiatal hernia is a condition where the top of your stomach bulges through an opening in your diaphragm. So if I go back to Find a Code, diaphragmatic hernia. Now I got to choose which one. I don't have gangrene in my diagnosis. I've got a diaphragmatic hernia without obstruction or gangrene. That looks kind of possible, doesn't it? Let's open it up.
He didn't say anything about an obstruction though either.
So I didn't have anything. So I've got my diaphragmatic hernia without obstruction or gangrene. So K44.9, I've got includes note. Look, there's my hiatus hernia. All right, and it also includes the paraesophageal hernia. Now, if my hiatal hernia was congenital, I couldn't code it here. But if it's not documented as congenital, we don't code it as congenital. Remember that from the congenital section.
So,
it's got to be documented.
So knowing what the word congenital means is vital to ruling out or selecting this code.
Good point.
You guys know do you guys know what congenital means? These are, you can see how every term, you hang on every term. I always think of it as it's been with you since birth.
Exactly. That's what it is.
Yeah.
And
Present there you go. Present from birth.
That was so quick. That was so quick to do my Google. Then we've got our notes. So if it's not congenital, it's definitely acquired. If I didn't have it at birth, I've acquired it since birth.
Yeah.
It wasn't documented as recurrent, which it would be included here, but you will see recurrent documented. All right. Excludes 2 notes mean that we can code it there, right? All right, then this is what I want to make sure that you're looking at and listening today. This right here, you need to read it. I mean, look at all this information just to grow into your brain, okay? That's pretty awesome, okay? All right, so what do we think our code is? K44.9, and we comfortable with that? We're ready to do our procedure code? And I'm gonna look back just to, well, it's on the other screen, so I'm not gonna do that. But what I wrote down, and make sure this is what y'all wrote down, esophagoscopy with biopsy. Did we write that down? Is that what we got?
Hey, it sounds like you always use a notepad and a pen or pencil, right? When you're coding a record and you're writing notes.
You have to, yeah.
Okay. Okay.
If you don't remember.
Can I ask, back to the diagnostic codes, I want a clearer understanding why the food impactment was not coded.
Okay. There is we don't have an impaction now. I can pull that back up.
Yeah, I think go back to the document. There you go.
Yeah. Let me get this situated here.
Okay.
All right. Good. Let's see where. All right. This patient has a history of the eosinophilic esophagitis with dysphagia. All right. The dysphagia, we didn't really talk about that, and I meant to, because that was a question that got brought up. So I'm glad we're backtracking a little bit. Dysphagia is a symptom of difficulty swallowing. And if you have esophagitis, that's going to be in your medical symptoms. Okay. All right. This patient also has periodic food impaction. That status just says that his history is a history of food impaction. He does not have it going on now. There's no, he's being treated for it. There was no impaction found in my operative report. Okay, so he's made mention of it. He's being treated for it, but he doesn't have it right now. It's just something that because of the esophagitis, because of that infection in there, and it's a bacterial infection, because of the severity of that infection, this patient has even had trouble swallowing with his food getting caught up in the esophagus. But we don't have that now. Does that help? Did I answer your question?
It helps. So does it mean that each time you see esophagitis with dysphagia, you don't call the dysphagia, you just call the esophagitis because it is a symptom?
That's exactly right.
Okay, thank you very much.
You're welcome. Thank you for your question. Let's go over here and code our procedure. We ready? So I'm going to put the entire description of my procedure in here just to see what I come up with. Okay? All right, so I've got options. Sorry, making sure my notes. All right, I've got an esophagoscopy, flexible. I believe I read that it was flexible, did I not? Okay. Transoral, through the mouth. There was no mention of doing the nasal cavity. So this is my other option here. My scope can be either flexible or rigid. Well, I've already said that it's flexible. Okay. And if you just kind of glance down here, none of these are applicable. We did not have a lesion removal. We didn't have any cauterization or a snare biopsy going on. But what I want to show you here is when you're learning that if you don't know what these others mean, take the time to open them up, okay? Take the time to open them up. But for the sake of time, we're going to open up this very first one and make sure that it matches the procedure that we're trying to code for our physician. Okay. I've got esophagoscopy, flexible, transoral. Do we know what that means? Through the mouth, with a biopsy, and it wouldn't matter if he took one biopsy or if he took three. Then I've got guidelines in here. It tells me that I couldn't report this with any of these codes. So are you taking the time to read your notes when you're coding? Because sometimes there's two procedures and they might not be coded together. And then if I've not gotten anything else across today, please take the time to read this. This is just like Googling this procedure. This is going to tell you what it is. And this is what it is no matter where you're coding at, okay? And then once again, if we wanted to look at chapter, section, guidelines, and note, you know, we could go through these, but we're not. I'll open it up just to kind of let you see. But our guidelines, see, if you come back and you read this, when bleeding occurs as a result, let's say this patient had something had happened in the procedure and they did control of bleeding just by cauterizing it. It's telling you right here, it's not coded. If you don't come down and open up the available buttons that are at the bottom of the screen, you're setting yourself up to code incorrectly, especially when there's more than one procedure.
Yeah. So if it had mentioned bleeding, you need to know what the rules are about how to handle, how to code. How does that affect coding when it does or doesn't occur?
Because let me tell you, if you do assign, let's say that we had bleeding, so we went and we coded, let's say he cauterized it, used a hot instrument to stop the bleeding. If we coded that along with this, there's a possibility it could get denied or somehow stall the claim, which slows down the physician's reimbursement. So it's careful that, we want to be careful that we understand. And this right here is an excellent tool that Find a Code has, giving you actual definitions. This is a big plus that I have found with Find a Code. Okay. All right. So our procedure is 43202. Let me write that down in my notes. All right. I'm going to actually minimize this because we won't have time to go through another chart. All right, let's see what we did here. All right, 43202. I did not have a modifier. We only performed one. Okay, and I'm going to link all of these because they were all part of the procedure. Okay. All right. And I'm going to submit. And we see that our codes are correct. And we see that we linked. Okay. So, but I want to show you the walkthrough because I do hope that you're reading these. All right. Because we're going to talk about the primary diagnosis and the secondaries. We even mentioned here that dysphagia is not coded. All right, and then we talk about the eosinophilic esophagitis. We talk about the code, and we give a little bit more information down here.
Yeah, there's not one error in the chart. I mean, they show up as red, right? When you make a mistake, you miss. I think they're shown as blue when you miss it, red when you put something that didn't belong there.
Yeah, right here. If I was wrong, it'd be red.
Yep.
If I'm correct, it's green. And if I didn't code something, like if I had left my hiatal hernia off, it would be blue. Let's go back and look. Yeah. All right.
I have a question.
Okay.
All right. From the Find My Code, coding from that part and coding from the index, which one is more correct? Because I personally, I love taking it from the index rather than from that at that point.
Instead of doing it the way I did it, Blessing?
Yes, Kelly.
Yes. And that's absolutely fine. As a matter of fact, if that's your preference, if that's what you're comfortable with, then that's where I want you to stay. So it's not a right or wrong, it's a technique. And it's what works for you and each of you. It's whatever works for you, how you find a code and find a code. Yeah.
Thank you.
You're welcome. Thank you for asking.
He asked the question, when you pass the certification exam and you're employed, do you work in a given specialty or all specialties? The answer to that question, Blessing, is it really depends. Depends. Usually when you're hired, you're asked to do a certain thing. No coder is an expert in all specialties. Ask Faye. I mean, we have some cardiology work that we needed done, and Faye's like, I'm not comfortable doing cardiology. I don't do it enough. So that's why when we identify what our customer needs are, we may ask you to go study and become more familiar with a certain specialty. The most important thing is that you learn how to think and understand, as Faye's done a really good job today of illustrating. Any one of you could become a specialist in any of the medical specialties by just spending enough time and coding records within that specialty. You'll learn it very well. You'll become more familiar with all the little terms, the medical devices that are used, and so on. So don't get too hung up on that. It's more that you're learning and having experience with all the little nuances of coding. So, but you'll probably only work within several specialties that you're asked to be an expert in. That'd be my best answer. And then he asked about whether there's a retirement age for coders. Faye, what would you say about that?
I hope not.
I'm great. It's great, Blessing. You're thinking about retirement already, but we're trying to just get you working right now. Okay.
Listen, I am so serious. There are ladies that I know. I'm just trying to think if I knew any gentlemen, but there's a few ladies that come to my mind that they're coders. They code. Not full time anymore because they've coded for years. So they're instructors now, okay? And they are in their 70s. Okay? So when you want to retire, it's up to you.
So when you're hit 70, Blessing,
we'll talk about retire.
Hey, most people that are in coding, they love it. Faye's experience about these retired coders, they love their work so much, they kind of do it their whole life. It's, hey, I'm going to tell you, I'm 65 years old. I still work every day, all day. So I love it and trying to help you guys learn this and get you on a career path that will bless your lives for the rest of your life. Whenever you decide you want to quit, that'll be up to you. You know,